Before I begin, because this is our first kidney biopsy conference of the year, we wanted to start by just introducing ourselves to our new fellows and any other new members of the department. So my name is Anand Patel. I'm the newest addition to our renal pathology group. I'm very excited to be here after just finishing fellowship last year. I have 5 wonderful colleagues here in our division, Dr. Alpers, Dr. Smith, Dr. Nicosia, Dr. Akalash, and Dr. Najafian. So we all look forward to working with you and with your patients and at our pathology at our grand rounds and other educational activities. All right, so I can move on to the next case. So I'm going to be presenting the first case for today, and I'm very fortunate to have Mahalet as my clinical discussant for this case. So I will turn it over to you, Mahalet, to go over the clinical history.
Thanks, and good morning, everyone. So I am going to be presenting on a case from late spring, early summer. She is a 22-year-old female with otherwise no prior medical history, and she presented with over 4 months of fatigue, hair loss, as well as progressive total body edema, new throat pain, and we were consulted for workup and management of acute kidney injury. I will note in terms of, starting off with her history that the history taking was actually quite limited by significant airway edema that was noted on CT scan that I'll share with you in a little bit. Patient was intermittently sort of gagging, clearing her throat, and so some limitations there. But she began having hair loss essentially and fatigue January of 2024. 2 months of increased total body swelling prior to presenting to our hospital. She also had some sore throat that started several days prior to her presentation, but no fevers or chills, no cough. She had initially gone to an outside hospital for about 3 days, and there they diagnosed her with pancytopenia, laryngeal edema, pleural effusions, and elevated creatinine. Unfortunately, we didn't have her records from the outside hospital, so I can't share numbers with you from there. And then she was told that she has a kidney problem and needed a kidney biopsy. They had sent autoimmune labs and they were pending on her way to us. And what she did is sort of self-discharge to UW for a sort of a second opinion. She wasn't sure that what she was hearing was true or necessary. But prior to discharging, she'd been treated with Solumedrol. And when I saw her, she was reporting some pleuritic chest discomfort as well as adynophagia, had hoarse voice and nausea, but otherwise didn't have rashes that she recognized, seizures, bleeding, focal weakness, dysuria, hematuria, changes in her urine output that she also recognized. As I mentioned, no prior medical history medications. She's currently unemployed and living with her parents. She'd recently finished school, I believe. No alcohol, tobacco, recreational drug use. She has a family history of diabetes in her brother and both grandfathers, and end-stage kidney disease requiring dialysis, I believe, in her maternal grandfather. No allergies. And then in terms of her physical exam, so she was afebrile, blood pressure not super impressive, 120s over 90s. She was tachycardic 100s into 110s, 88% on ambient air, and she's requiring 2 liters of nasal cannula at this time. She's appeared young, but in mild distress. She did have some scattered erythematous plaques that were sort of overlying with some overlying scale on the anterior scalp, but the hairline with pretty notable hair loss, no malar rash. She did have some facial swelling, maybe right greater than left. She had a pretty hard time opening her mouth in order for us to visualize due to pain and discomfort swelling. As I mentioned, she's tachycardic, didn't hear extra heart sounds, but she was sort of anosarchic diffusely. Her lung sounds were diminished in the basis, but otherwise clear to anterior and lateral auscultation. She had quite a bit of discomfort with sort of passive movement of her extremities, but no effusions or erythema at the joints. Speech was hoarse, and her affect was a bit flat, but those were the notable exam findings. In terms of her lab results, so starting with her chemistries, notable for potassium at 5.8, Her bicarb was 18, her creatinine 3.5, and again, I'm presuming that she had normal kidney function prior, but no labs to compare there. Her platelets were within normal, but otherwise she was anemic and leukopenic. Her albumin here, as you can see, is less than 1.5. And then in terms of a urinalysis, 3 plus protein, 2 plus blood here, and then her protein creatinine ratio at 4.2 with her ACR over 1700. Her complements both low, her kappa lambda ratio at 1.5, and then polyclonal, no monoclonal component. Her ANA was positive, and her anti-double-stranded DNA titer was at 5,800, with a strong positive anti-smooth muscle RNP. We also did some antiphospholipid testing that showed that her anti-beta 2 glycoprotein positive at 30, and then anti-cardioglobulin also positive. Her anti-PR3 and anti-MPO also positive. Her imaging notable for a renal ultrasound showing echogenic kidneys, but otherwise no hydronephrosis stones. It did show quite a bit of significant bilateral pleural effusions and then mild ascites. Her TTE results were quite interesting. So her pericardium was mildly thickened, and she had moderate amount of pericardial effusion, about 1.6 centimeters at its largest. And there was some concern for increased intracardiac pressures. Her IBC small and collapsible otherwise with a CVP at 0 to 5 and normal PASP, normal EF. I mentioned the CT neck to you, so it showed diffuse body wall, edema, and prominent lymph nodes. They did mention that they couldn't exclude if there was potentially an infectious or a component to this. And again, the pleural effusions did. We attempted to do, I believe it was Friday afternoon, and we attempted to do a bedside kidney biopsy after she returned from placement of a line from IR, but she'd gotten a number of medications and was quite somnolent, unable to follow directions. So we scheduled the biopsy for the following Monday on the 15th. Initially, here is what she's received. So actually, prior to calling us, I believe she'd already had a dose of IV methylparadigms, 500 milligrams. And so we planned on continuing that for 3 days and then tapering from there. Started on hydroxychloroquine at 200 milligrams daily, given the degree of proteinuria as well as her albumin creatinine ratio less than 1.5. Started Eliquis at 2.5 milligrams BID. Suppose this is after the biopsy, of course, and then her Lokelma and Lasix weren't able to sort of keep proteinuria at bay, and she'd been anuric. That's why I didn't have a urine sediment for you for greater than 3 days. So she did have dialysis ×1 on the 11th, and really didn't require it afterwards.
All right. Thank you very much, Malette. So at this point, if anyone has any questions about the clinical history, feel free to go ahead. And then in the meanwhile, I will have you use the annotate feature to tell me what's in your differential diagnosis. You can have multiple possibilities. I believe I've set it so that your annotations are anonymous. If you have other thoughts, you can either type them in the chat or shout them out. All right, so it looks like we have a pretty high suspicion for lupus nephritis with a few other glomerular processes in the differential. So let's take a look at the biopsy and find out what we see. Okay. Sorry, I have to find the clear annotations button, which I'm not seeing. Oh, great. Thank you, whoever did that for me. All right, so here's how the biopsy looks at low power. we have, this is one core that I've split into 3 pictures. And so I'm going to start with a simpler question. Let's start with annotating where in this biopsy do you see medulla? So we have both cortex and medulla in the sample. Yes, that's right. So we have a piece of medulla here at this end of the biopsy, and then the rest of this biopsy is cortex. For this particular case, nothing exciting in the medulla. We're going to focus on the renal cortex. And one more question about this at this low power view. One of the first things that we like to do is just look at low power and evaluate what do we have and how much of the sample is preserved versus scarred. So go ahead and put an annotation next to how much chronic injury you see in the renal cortex up at the top. Yeah, so we're between none and mild. So at this low power view, I pretty much don't see any chronic injury, maybe one very tiny area where the tubules aren't quite back to back, and there's a little bit more black matrix in that area, but most of this looks very well preserved. All right, so now I'm going to take you through the glomeruli, and I'll just run through a few images, and then we'll talk in more detail about what we're seeing. So I didn't have a comparison of what a normal glomerulus looks like, but hopefully you can recognize that this glomerulus is quite abnormal. And here's another glomerulus with a very similar appearance. A third glomerulus, a fourth glomerulus, and a fifth glomerulus. So I'm showing you 5 out of the maybe 15 or so glomeruli that were present in the sample, and they all pretty much looked the same. And what we're seeing is, so normally when I'm looking at a glomerulus, the first impression I get is based off of how much white space is there. Am I seeing open capillary loops, and am I seeing open urinary space? And in this case, we can see the open urinary space, but we're really not seeing the capillary lumina. And that's because there's a lot of this pink or eosinophilic material, and there's a lot of cells. So I'm first highlighting some of this eosinophilic material, and what do you think this eosinophilic material is? Is it hyaline material from a scarring process? Are these fibrin thrombi? Are these immune deposits, or is this amyloid? Okay, I am seeing a spread here, which is great because it's this kind of eosinophilic material. It can be really hard to distinguish between these 3 possibilities that all have a pretty similar color and textural appearance, and they all can occur within the capillary loops. So it looks like more people are suspecting immune deposits, and that is correct, but it's not super obvious to tell just by light microscopy alone. So fortunately, we have immunofluorescence that we'll look at later that will prove it and just characterize these further. But as we'll talk about later, this pattern of deposits are sometimes described as hyaline thrombi, which is highlighting the similar appearance that these 3 different types of material can have, where the term hyaline thrombus is a misnomer because they look like hyaline and they look like thrombi, but they're really immune deposits. So we will come back to that in just a minute. Now we're going to take a look at these cells that are also filling in a lot of these capillary loops. And I'm highlighting a few of the cells. There's a mixture of different cell types in these capillary loops. But what do you think of these cells that I've circled? One here and one here. And yes, I see several votes for neutrophils, which is correct. So these we can identify neutrophils by having these multiple lobes to their nuclei. So to summarize what we've seen so far in the glomeruli, we see a diffuse process, which is a glomerulonephritis that's characterized by increased cellularity in the capillary loops, which includes some neutrophils, and we're also seeing some prominent immune deposits. All right, so normally we would go systematically through all the compartments and look at the tubules, interstitiums, and vessels, but in this case, there was not very much to speak of in those other compartments. So I'm going to move on to immunofluorescence microscopy. And here is what we have. So we have really bright staining for all three heavy chains, IgG, IgA, IgM, as well as our two complement components that we stain, C3 and C1q. So this is what we describe as a full house pattern, 3 of a kind and 2 of a kind. And this gives you the confirmation that that eosinophilic material we were seeing by light microscopy, we're seeing corresponding immune deposits by immunofluorescence microscopy. So when we look at immunofluorescence, we don't just want to say, is it positive or not, but we also want to characterize how strong the staining is and where are we seeing those deposits. And in this case, the architecture of the glomeruli is pretty severely distorted, so it's hard to tell with complete confidence what if you point anywhere in the glomeruli, it's hard to tell exactly where we are, but hopefully you can appreciate that basically the entirety of the glomerulus is staining, and so that tells us that they're staining both in the mesangium and in the capillary walls. And in a few minutes more, we will look at electron microscopy, which can help us to more specifically localize where the deposits are. I'm showing you some additional images of C1q. And so we see these circular structures that are also have positive staining. And another question for you, where do you think these deposits are? Are we seeing Bowman's capsule of glomeruli? Are we seeing the tubular basement membranes? Are we seeing arterial vessels, or are we seeing peritubular capillaries? And you are all correct. These are the tubular basement membranes. So we have extraglomerular deposits in the tubular basement membranes. And then in this same image, we're also seeing some smaller circles that also have a positive outline. And what are these deposits in? And yeah, these are the peritubular capillaries. We see these smaller profiles sandwiched in between the larger tubules. Okay, and then in IgG, we're also seeing the staining of the tubular basement membranes. There are probably some peritubular capillaries in here as well. And then I also want to point out, so here's the outline of a tubular basement membrane, and then within that tubule, we see some positive staining within the nuclei. So this is what we call a tissue ANA pattern. So we're seeing staining of the nuclei, and this gives a correlate with the serologic testing of ANA. All right, so to summarize what we saw by immunofluorescence, we have a full house staining pattern, which is in the glomeruli, both in capillary walls and in the mesangium, as well as extraglomerular deposits in the tubular basement membranes. I didn't show you the arteries that had some deposits, and then in the peritubular capillaries. All right, so we're going to characterize these, the location of these deposits by electron microscopy now. But before I show you examples from this case, I'm showing you a normal EM for comparison, just so that you have a sense of how to orient yourself in EM. If you're lucky, you can catch a red blood cell that helps you identify that this is a capillary loop. There's the endothelium on the inside, which should be a relatively flat cell layer. And don't really pick them out that well, but there are a few fenestra, the gaps within the endothelium. Then there's the basement membrane, and then on the outside, we have the podocytes with their foot processes. And so when we look for deposits, we're going to try to identify these structures and then ask, are the capillary wall deposits subendothelial, meaning they're between the basement membrane and the endothelial cells, or are they subepithelial between the basement membrane and the podocytes? And then we'll also look for deposits in the mesangium, which is this structure here that's sitting in between the capillary loops. So here's a lower magnification EM image from our case. And I tried to give you that overview image before to orient you, but that kind of goes out the window when you see this image, and there's really not much recognizable structure because, as we saw by light and immunofluorescence microscopy, the architecture of these glomeruli is very severely distorted. But if we look closer, we can try to get some clues about where these deposits are coming from. So in this image, we're catching just a very small open space here that corresponds to the capillary lumen. And the way I can tell that, partly I can tell that it's lined by some cells here. It's hard to tell that these are endothelial cells just by looking at them. But then we have a basement membrane here. And then on the outside, we have podocytes, and we can see they have these cytoplasmic processes, which are typical for podocytes. So we have endothelium, basement membrane, podocytes, and then we have all this electron-dense material, which are the immune deposits, and they're sandwiched between the endothelium and the basement membrane. So we have very large subendothelial deposits here. Here's a closer view of that same image. So here's the endothelial cell, here's the immune deposit, and then there's a little bit of basement membrane on the outside. And there's maybe also a little bit of immune deposition on the subepithelial side of this basement membrane. Here is another image where we're seeing podocytes on the upper left corner. We have basement membrane, and then we have deposits. And in this case, we can't tell for sure what cells are down here, but this looks like it's probably subendothelial or maybe at the mesangium where the basement membrane is reflecting off of it. And so most of the EM images looked like these ones where there were really large deposits on the subendothelial side of the capillary walls. Here's one example of a more rare occurrence in this case where there are some immune deposits on the subepithelial side. So here's the podocyte on the bottom to bottom left corner of this image. There's the basement membrane, and then this is some endothelium on this side. And so we have some immune deposits here on the subepithelial side, but then there's also these deposits that are spanning the basement membrane and then on the subendothelial side. All right, so as you all correctly predicted, we have findings that support lupus nephritis. So one of the generally to outright call a case lupus nephritis, we want there to be a clinical diagnosis of lupus. And in this case, the diagnosis wasn't established yet, but we have other findings that make us pretty confident that this is in fact lupus nephritis. By immunofluorescence, we have a full house staining pattern where we had strong staining for all of the heavy chains as well as C3 and C1q. You don't have to have a full house to get a diagnosis of lupus nephritis, but it certainly very strongly points to lupus when you do have a full house. And in particular, having strong C1q is a major indicator that there's lupus versus another immune complex process. And then we saw extraglomerular deposits, which also support lupus nephritis, although they can be seen in a few other conditions. In this case, we did not see this additional finding of tubular reticular inclusions. That's what these structures are within glomerular endothelial cells. And tubular reticular inclusions are not entirely specific for lupus. They can be seen in other conditions with high interferon states. And they're also not terribly sensitive. So the absence of tubular reticular inclusions does not help exclude lupus, but if you see them, that can be strong supporting evidence for a diagnosis of lupus nephritis. All right, so in this case, because we didn't have an established clinical diagnosis, we didn't outright call it lupus nephritis, but I think we said something like consistent with or strongly suggestive of lupus nephritis, basically saying that it's almost certainly lupus nephritis, even though we don't have the lupus diagnosis to outright call it, because it had all of these other features very prominently. So when we're evaluating a lupus case, making the diagnosis of lupus nephritis is only the first step, and you're all very interested in some additional information to help you understand what type of lupus this is, how is the patient going to do, and how should you treat the patient. So I'm just going to briefly go through how we describe and classify cases of lupus nephritis. So there's a few different classification or scoring schemes that we use. The first is the ISN RPS classification, where there are classes from 1 through 6. And I'm omitting class 1 and class 6 that we almost never see because class 1 cases have almost no symptoms, and so they don't get biopsied. And then class 6 are at end stage, and so they also tend to not get biopsied. And so I like to think of these classes based off of where you see deposits, and then from there you can understand what you expect to see in the biopsy to go with those deposits. So in class 2 lupus nephritis, the deposits are only in the mesangial regions, and so the only major finding you'll see by light microscopy is an increase in mesangial cellularity. But because there are no deposits of the capillary walls, you don't see any additional findings besides the mesangial changes. In class 3 and class 4 lupus, in addition to those mesangial deposits, there are also subendothelial deposits in the capillary wall. And these subendothelial deposits, being on the side closer to the capillary lumen, can elicit a stronger immune reaction and cause damage to these glomerular capillary loops. So in class 3 or class 4 lupus, you'll see the active lesions of lupus nephritis that we'll discuss later. You can see increased cells, you can see crescents and necrosis as this capillary wall gets destroyed, and some other findings that we will look at in just a minute. And then in a and the distinction between class 3 and class 4 is based off of the percentage of glomeruli that are involved by these active or chronic lesions that are associated with the subendothelial deposits. And then in a class 5 is membranous lupus nephritis. And so in class 5, you see deposits on the subepithelial side of the capillary wall. And so this is what causes the membranous pattern of injury. But because they're kind of on the outside podocyte side, you're getting the proteinuria that you associate with membranous nephropathy without necessarily expecting the active lesions of lupus nephritis, although you might find a few isolated subendothelial deposits and mesangial deposits in these cases as well. And then it's possible to have a class 5 in addition to a class 3 or 4 if you have deposits in all 3 of these locations, mesangial, subendothelial, and subepithelial. So that's why we can have a class 3 plus 5 or a class 4 plus 5. So in cases of class 3 or class 4 lupus, you're interested in not just that classification, but also the extent to which the findings are active versus chronic. So we give it an A, a C, or an A plus C, depending on whether we see activity, chronicity, or both. And in our biopsy today, we had a class 4 because we were seeing active lupus lesions in essentially all of the glomeruli. Okay, so I'm short on time, so I'm just gonna very quickly breeze through some of these lesions that we look for in lupus nephritis. And these all form part of the NIH activities and chronicity scores. So segmental necrosis and crescents are the ones that are the most severe. They get double the points in the NIH score, and these are caused by breaks in the glomerular basement membrane that we're seeing here. And in segmental necrosis, you'll see accumulation of fibrin, which is this ropey pink material. And then as a crescent, as you're all very familiar with, you have an increased number of cell layers in the urinary space. You can see increased endocapillary cellularity in an active lupus nephritis, which I'm showing in this PAS stain, where in this portion of the glomerulus on the left, we see open capillary loops, whereas on the right, those capillary loops are occluded by cells. There's an additional scoring system for the percentage of glomeruli that have neutrophils or karyorectic debris, which are these little small black speckles that are related to the disintegration of neutrophils. And then the lesion that we saw the most of in this biopsy are what are called hyaline deposits or hyaline thrombi, which, as I mentioned before, are misnomers because these are not truly made of hyaline material and they're not truly thrombi. But these are large deposits of subendothelial, these are large subendothelial deposits. And sometimes those deposits will herniate into the capillary loop and look like they're occluding the capillary loop when in fact they're still within the subendothelial space and just protruding into the lumen. So that's what these are here. And then this case didn't have as clear examples of wire loops, which is the same process of subendothelial deposits, but they form a rim going all the way around the capillary wall. Okay, and then we also score the chronicity. I'm showing just a few examples of segmental sclerosis and fibrous crescents, which are closely related to each other. And then there's also scoring for global glomerulosclerosis and for tubular atrophy and interstitial fibrosis. So to summarize, in this case, we had a diffuse lupus nephritis, which was class 4. It was predominantly active, but there was one sclerosis glomerulus that got it, and also called a chronic in addition to active. And then here are the activity and chronicity scores, where there was endocapillary hypercellularity, neutrophils, and the hyaline deposits, but no crescents or necrosis. All right, and then Mahalet, if you want to briefly go over the follow-up. Sorry, I didn't leave you very much time.
No, that's okay. I think I can sum up the follow-up in saying that she has had a very complicated course. So she got discharged from the medications above, but then was readmitted in the setting of methemoglobinemia, then developed seizures and enhancing lesions, negative for PML that were then concerning for lupus cerebritis. She's finally sort of resolved that, and then now may have some acanthamoeba. She had CMV in the interim. So there's been a lot of admissions. But I think the last point, one more, is that, is that her creatinine baseline is 1.1 to 1.3. So she's doing better from that perspective. And she hasn't needed dialysis since June. It's just that now I think she stopped all immunosuppressives and is tapering down on the prednisone in the setting of the acanthamoeba and needing to start on multifazine to address that disseminated infection. So I'm curious to see what happens with her kidneys.
All right, thanks everyone for participating. I'll hand it over to Dr. Akalesh, who has the next case. If you have questions, you can put them in the chat while we go.
Great, thank you, and thank you for such a great introduction. I think that'll be a good setting because Sarah is going to do double duty perhaps with both Roberto and my cases, and we'll try to go through them quickly so that you can go straight to the biopsy findings. But Anna has laid the foundation for that pretty well. So Sarah, I'll let you kick off the first case.
Great. Can everyone see my screen here?
Yep.
Okay. And let me just make sure I am on slideshow view. All good?
Not yet. Not yet.
Not yet?
Yeah.
Okay, give me a second. Let me see if I can rotate them.
I think you might be on the second case.
Oh, I think I switched them. But do you guys see slideshow view?
No,
Not
I think
slideshow view. Yeah.
You're good, Daniel?
No, I think we're just seeing your presentation like in, I guess, edit form or.
Oh goodness. Okay, give me a second.
Yeah.
Okay, let me go to slideshow first and then reshare. Sorry guys, 1 second here. Okay, this should work this time. How's that?
That's perfect.
All right, there we go.
All right.
Yep.
Okay, we're in business. Thank you, Anand, for that great introduction, because that's going to help us with our next 2 cases if we have time for them, which I hope we do. So welcome everyone, beautiful fall Seattle morning. I'm Sarah Sangavi. To help me is Dr. Akalish and Dr. Nicosia, who you guys know well. And just so everyone knows, there are a lot of details in this case, but both patients were consented to have their cases presented and to be on social media. So we'll go ahead and start right now. This is a 47-year-old man. He has polyarticular erosive arthritis. He's on methotrexate, hydroxychloroquine, and prednisone. He came to an outside hospital. This actually all starts in 2019, so we've got a journey here. With 1 month of worsening edema, 3 weeks of fatigue. His creatinine on admission was 4.1 from a baseline of 1.1. And he was noticed to be quite anosarchic on that admission. He had a pretty complicated course with acute respiratory failure requiring mechanical ventilation, MSSA, pneumonia, and septic shock. And through this time required 2 weeks of dialysis. During his course, he was also noted to have a right knee effusion, and that was tapped, that showed negative crystals and negative cultures, but he did have a WBC count of 60,000, suggesting it was quite inflammatory. He had a renal workup during this time that included proteinuria of 1.3 grams per gram, a positive ANA at 1 to 160, and he had a positive double-stranded DNA, again, at the outside hospital that was 8.2. He had a kidney biopsy at this outside hospital that was performed near the end of this 2-month admission. He had one that had inadequate tissue, and then this was then repeated 3 weeks later.
Great. So we don't unfortunately have the slides from that first biopsy, but we do have the report. And Dr. Nicosia also had a chance to, when he was at the VA, give his impression as well. So there were 2 biopsies. The first was basically inadequate. There was a little bit of material for the immunofluorescence, so they did a repeat biopsy. But both showed a very modest glomerular immune complex deposition, really minimal, completely in contrast to the pictures that you saw that Anand presented. There was also a little bit of chronic glomerular injury. It was suggestive of some resolving scars, some like segmental sclerosis, but there was no activity in the glomeruli. So all those active lesions that Anand showed you, there were inflammatory cells coming in, destruction of the glomeruli were not seen in this biopsy. There was a little bit of tubulointerstitial nephritis as well, and some moderate tubular atrophy and fibrosis. Next slide, please. So going into some of the findings, about half the glomeruli in a sample of 26 were globally sclerosed. Again, no active lesions in the glomeruli. Really, only the changes we were seeing were maybe a little bit of mesangial hypercellularity and some segmental scarring. So remember now this patient has anasarca, interestingly, only about 1 to 2 grams of protein, but is showing some correlate with that in terms of the segmental sclerosis. And then there's this question, could this be an immune complex process? Could this be lupus? Really, the findings were not super supportive of that. So next slide, please. So now the key things here is that there was that modest immune complex deposition. And what they meant by that was maybe about 1+. And so we here use a scale of like 0 to 4+ in terms of intensity. It's kind of semi-quantitative. It sounds kind of arbitrary, but we're actually fairly consistent amongst ourselves to call this. And so really in our mind, generally when the intensity hits about 2+ is where we think it's real and has to be accounted for in the diagnosis. So this biopsy, their interpretation of the outside lab was really, really modest. It was barely 1+ at most. And most importantly, as Anand already said, C1q, which is really kind of a signature complement activation component in lupus, was very weak in that first biopsy and negative in the second biopsy. There were no deposits outside of the glomeruli, and even EM was pretty underwhelming in terms of the number of the deposits, which were really scarce. There were no tubular reticular aggregates in the endothelial cells, but there was foot process effacement in most of the capillaries, maybe providing a correlate for the proteinuria. Next slide, please. So Dr. Nicosia saw this, and he was not impressed that this was, supportive of lupus nephritis. So even though there was clinical suspicion, the biopsy findings really didn't check many of those boxes. There were no extraglomerular deposits. The amount of immune deposits was pretty minimal. C1q as kind of that signature component was not present. And even the EM findings were pretty underwhelming. So while technically this could have been considered if the patient met criteria for lupus, which he did not, I believe, at that time, if he met criteria, it could be considered a chronic or resolved phase of lupus nephritis. But really, there was nothing to support an active disease process at that time.
Okay, great. And I think I will say that the reason we obtained the slides and had Dr. Nicosia look at them again is because when this patient transferred to us just for rehab, we really couldn't see clinical signs of lupus. So he had been treated with mycophenolate at 1 gram BID, prednisone, and his creatinine continued to improve. So he started out, and you'll see down here, in February of 2019 that he had a creatinine of 4.1. By the next month, it improved to 2.5. And so in discussion with our rheumatology colleagues, we had the slides sent over. We sent more diagnostic tests, which I'll get into in here in a minute. Unfortunately, his course in rehab was complicated by MSSA septic arthritis of his right wrist. So just some diagnostic tests that we performed. He had a C3, which was normal at 150, a C4 normal at 29. Anti-cardiolipin was negative, hep serology is negative, cryos were negative. He didn't have leukopenia or thrombocytopenia. His hemoglobin was lower at 8.2, but he also had been quite sick through his hospitalization, which is now spanning about 3 months. In terms of specific lupus labs, his ANA, the direct ELISA was positive, but you can see, and this was looking at 2019 here, his ANA was negative when he first came in and then low titer at 1 to 160 about a month later. I did find some 2011 labs, which I thought were interesting, so threw them in there. So 8 years before he really had any manifestations of disease. His patterns were here nucleolar and homogeneous. And it was nice that Mahalet showed you the high salt avidity dsDNA, because that was what we were using in some of these tests here. And she had a patient who had one of 3580. Ours were mildly positive at 14, 14, and 10. His proteinuria was 0.74 grams per gram. And as mentioned earlier, his creatinine continued to improve. You can see here that it continues from March all the way to April while he's still in rehab to improve up to a GFR close to 60 here. So his outpatient follow-up, he lives quite far away, but we're able to see him and take care of him. So he was tapered off MMF after 20 months of therapy, mostly because his erosive arthritis, his polyarticular arthritis that was not thought to be lupus, was really getting worse, and he needed more tailored therapy for that. At this time, his creatinine was 1.5, his UPCR was 0.3 grams per gram. In 10 of 2020, after he was off the MMF, we repeated a serologic workup. And again, his high salt avid dsDNA was just slightly elevated. His ANA immunofluorescence was negative at this time. He was started on leflunomide with prednisone and hydroxychloroquine, which he had continued through this time. In July of 2023, and so you can see that COVID years intervened between 2020 and 2023. But then in July 2023, he was hospitalized for a 10-centimeter abdominal wall abscess that was E. coli, and he had sepsis related to that. He probably also had some relative adrenal insufficiency because he had run out of steroids at that time. In September of 2023, he finished the antibiotic course for this abscess, and he was started on abatacept and a slow taper of his prednisone, really 1 milligram per month from 10, in the hopes that they could finally get him off prednisone. We do have labs from just April of this year, which showed that his creatinine was still 1.58 and his urine protein to creatinine ratio was consistently less than 1 gram. Unfortunately, then he is admitted again to an outside hospital, this time with 3 days of left lower extremity edema, worsening erythema, pain consistent with cellulitis, a few areas of his leg with skin breakdown, and some purulent discharge. He's treated with IV zinc, ceftriaxone, and Flagyl. These are his admission vitals, which show that his blood pressure is 145/87. He does have a white count of 27. His lactate is only 1.7, but his creatinine has now risen to 2.7. He has very high inflammatory markers. Albumin's 2.4. He had a urinalysis done on admission that showed 16 to 25 WBCs, some RBCs, some 2+ protein, but only rare bacteria, and it didn't reflex to culture because of that. His blood cultures on admission were negative, but his wound culture was positive for strep pyogenes. He had a serologic workup done because they knew about his past history, and he had a positive ANA. Double-stranded DNA, again, mildly elevated, almost the exact numbers as before at 14. He had normal C3, normal C4. Rest of the workup was negative. So his hospital course, unfortunately, the next day, things looked relatively stable, that quickly deteriorated from then. His creatinine rose from 2.5 to 5. At this time, a renal ultrasound was done and showed fairly large kidneys, 13.7 and 13.1, no stones, masses, or hydro. And then they did get a 24-hour urine on day 5 of his admission that showed a decent amount of urine, which was encouraging at over 1 liter, and 0.76 grams per gram of protein. He was really nearing dialysis at this point, and a biopsy was performed at the outside hospital. I wish I could get credit for this one, but
yeah, this was
3 centimeter core was not mine.
Yeah, so this was an amazing core, both cortex and medulla, as Anand already gave you a preview of the different histologies. But interestingly, even though it was gigantic, there were very few glomeruli in the sample, and that sometimes happens. So there were only about 5 to 9 glomeruli per level. And interestingly, most of them were actually completely sclerosed. So there was a little bit of a discordance between the extent of glomerular injury and the tubulointerstitial injury, which appeared a little bit on the mild to moderate side. So it's interesting, Sarah, with this patient as well, just thinking again, looking at the history about the recurrent soft tissue infections, that abdominal wall infection, now cellulitis. And so let's consider that again. So next slide, please. So when we start zooming in, we can see that there's a lot of things that are abnormal here. So first of all, right in the middle, you can see a lot of white space. Those are tubules that are acutely injured. But in addition, as you scan from left to right, you can see that the tubules themselves, the profiles are spaced apart. There is material in between that's pushing them apart, and we'll take a closer look in the next few slides as well. Next slide, please. So here's another view. Again, this is a very uniform appearance throughout the biopsy. Here, actually, we don't see very many tubules, or if you look right in the center, instead we're seeing a lot of dark blue cells, which we'll look at in higher power as well. Next slide, please. So here's a higher power view of a few of the patent glomeruli. So this particular glomerulus looks fairly unremarkable. So again, comparing your mind to the features of active lupus nephritis that Anand and Malet presented. So we're not seeing mesangial hypercellularity very prominent in this glomerulus. We're definitely not seeing inflammatory cells coming in, no wire loops, necrosis, crescents, none of that. This looks like a pretty bland looking glomerulus. But if you look to the right, you can see the tubules are, instead of having tall columnar epithelium that almost fills the lumen, they're instead seem kind of attenuated, more cuboidal in shape. There's a kind of a apparent widening of the lumen with more white space. And also you can see between the tubules that there's a lot of kind of gray material. This is interstitial edema. And there are also inflammatory cells in there, which we'll look at further. Next slide, please. So now this is another glomerulus. This is a PAS stain. And here you can see an occasional mesangial hypercellularity. So if you look at kind of the 12 o'clock position of that glomerulus, there's a little extra pink material. There are a few more nuclei than there should be in that area as well. Thank you, Sarah. And so that's again where we were seeing mesangial hypercellularity, which was reported in the prior biopsy in 2019 as well. But we're not seeing any activity associated with it otherwise. So let's continue. So as I told you, the glomeruli were pretty bland, but the interstitium, there was a lot of activity here. So this is really a hot looking inflammatory infiltrate. there were several areas where there were tons of neutrophils that were infiltrating into the interstitium. And neutrophils, again, as Anand pointed out, have that kind of polylobated nuclei. I think of them all as like little black ants kind of crawling through the biopsy. And so there were several foci where the neutrophils were kind of overrunning the interstitium and also infiltrating the tubules as well. In addition, we'll see some eosinophils, which are distinguished by their kind of red granular cytoplasm. There are a couple of higher power images as well that I'll show you that, in a slide or two. Next slide, please. So this was kind of a diffuse process. And so in addition, we are seeing those same neutrophils within the lumen of some of the tubules. So you can see a couple of tubules here that have neutrophil-containing casts. So these might show up as granulocyte casts in the urine as well. This case had some of the most impressive casts that I've seen. Next slide, please. So for example, here's a giant neutrophil containing cast, I think the biggest one that I've seen. And they're just it's kind of stuffed into that tubular lumen. And again, when we see this, we really start worrying about infectious processes in the kidney. Next slide, please. So here's another view of those same neutrophils. And now here they're surrounding a tubule, which is seen in the center. But if you follow them, they're kind of all kind of sitting at the periphery of that. And instead of having a nice distinct basement membrane, which is outlined by black, you can see that there are discontinuities of the base membrane as these neutrophils are kind of attacking and devouring this tubule almost from the outside in. So this is inflammation coming from the interstitium attacking the tubule. And so really the impression was more of an interstitial inflammatory process that was secondarily involving the tubule rather than a more ascending process originating from the tubular lumens coming out into the parenchyma. Next slide, please. And finally, here's a little bit of concentration of the eosinophils, which have kind of the more reddish granules here. Again, there was a ton of inflammation throughout the entire biopsy. There was a lot of neutrophils. Having a few eosinophils with this much tubular destruction is perhaps not that surprising, but nonetheless, we wanted to note that just in case thinking about an allergic type process as well. Next slide, please. So immunofluorescence, in contrast to Anand and Malet's case, was completely negative. Electron microscopy also is essentially negative for any immune deposits. On the left, you can see that there's a little bit more of a mesangial cell processes that were a little bit more pronounced in the mesangium that correlates with the mesangial hypercellularity we saw by light microscopy. And overall, there was about maybe a 30 to 40% podocyte foot process effacement, maybe correlating with the proteinuria as well. But again, all the features that we would think about for active lupus disease, we're not seeing immune deposits. We did not have full house immune complex deposition, no C1q, no extraglomerular deposits, no tubular reticular inclusions. So this really didn't look like an immune complex process. It matches the very quiet looking appearance of the glomeruli. Really all of this, the disease process, the major injury is occurring in the tubular interstitium. Next slide, please. And so really, I was very concerned for an infectious process, either hematogenously seeded or even ascending. And so I rendered a diagnosis of acute pyelonephritis. And there was acute tubular injury, and also eosinophils were prominent. Again, with this, in this scenario of the wound infection, the key thing I wanted to make sure that was done was that infection was ruled out. It is possible that, these are all represent a kind of a sterile type of acute inflammation. The patient had been exposed to multiple antibiotics by this point. There were some eosinophils in the infiltrate as well. But given the history, I thought it was important to at least rule out infection first, and then consider these other possibilities. We did not see any evidence of a lupus-like disease in the current biopsy. So given that concern, the frozen material here was also sent for bacterial DNA sequencing just yesterday. So we'll see if that shows up any positive findings there. So back to you, Sarah. Next slide.
Great, thank you. And I will say, just to give credit to Sarah Hager, one of our first year fellows, who when we were chatting about this case, recommended like, oh, send the tissue for DNA polymerase. And the main reason for that is that the urine culture that we asked for 14 days after admission, because that's when I actually got involved in this case, when the patient called me to tell me he was admitted to an outside hospital and what was happening, showed no growth. We asked him to start IV ceftriaxone anyways, because he had been switched to cefazolin, which doesn't have great kidney penetration for his cellulitis, and never really got a full course for a urinary tract infection. After starting ceftriaxone, they did repeat another urinalysis just a couple of days ago, which show that he continues to have significant amounts of WBCs, RBCs, and again, very few bacteria. So he's going to get his full 14-day course. He is still on dialysis. He is making some urine, but not that much. And so we're just going to have to see how things go for him. So that's the follow-up. It looks like we're not going to have time for our second case, so I can stop there and see if there's any questions. Seems quiet. All right, I'll hand it back to Daniel then.
All right. Well, thank you guys. Yeah, and very, very interesting cases. Hopefully we'll get to that last case maybe at a later conference. But we're at the 9:30 mark here. Does anyone have any last questions or comments about our conference or any of our talks today? All right. Well, if no other comments, thank you everyone, and a wonderful weekend. We'll see you guys back next week for another Zoom grand rounds. All right. Bye, everyone.